thought that it would be really helpful to start with a grounding in the kind of national and historical perspective on public health, essentially a landscape review, right? And we want to do that to put our conversations later today in context, and who better to provide that context than literally the authority in public health in America, Dr. Georges Benjamin. So a couple, he needs no introduction again, but I will, of course, introduce him. Dr. Benjamin has been the executive director of APHA since 2002. He started his career and was sharing earlier some of his stories from earlier in his career as a military physician. He eventually ended up at Walter Reed, stationed at Walter Reed, before he eventually transitioned into DC government, where he held a number of prominent roles in the DC Department of Health, before, of course, where a lot of the folks in the room got to know him so well, coming to the Maryland Department of Health and Mental Hygiene, where he served as secretary. Since then, he has, of course, been an incredible leader and shaper of the landscape here in Maryland for years and years. Please join me in welcoming Dr. Georges Benjamin. So, as Dr. Benjamin comes up, we'll be having a little bit of a discussion here. He'll provide some remarks, but then please think of questions for Dr. Benjamin. We'll have mics around the room toward the end of the conversation. Please join our discussion here. So another round of applause. Thank you, Dr. Benjamin.
Well, thanks, John. I thank you for allowing me to be here, and good morning, everybody. You know, I like to talk a bit about health, and I really like to use the World Health Organization definition for health. And just to remind you what it is health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I think it's also important to understand that that's not just physical health, that's also mental health. And we as a nation are failing that definition. I would like to say that we are in the business of achieving optimal health. I mean, otherwise, why are we doing what we do? And yet, we as a nation just aren't doing as well as we really could. Life expectancy in the United States has now fallen. It's about 76.4 years. That's about the lowest it has been in 2 decades. Now, certainly COVID played a role in that. There's no question about that. But it wasn't just COVID, because we've been declining compared to other nations for some time. And we're not even achieving what is possible, right? Everyone here knows that we spend much more than any of the other industrialized nations on quote-unquote healthcare. And we aren't achieving anywhere near the results. I mean, depending on who's counting, on the big list, we're about 46 compared to other industrialized nations. We have an infant mortality rate which is higher than Cuba. Not to say, pick on my colleagues in Cuba, but, they've got a great primary care system. And we just haven't quite figured out, with this abundance of money, with these amazing healthcare systems. I'm recovering from hip surgery, and so I'm absolutely amazed at what we can do now with little bitty incisions. But we're just not getting the kind of outcomes that we think we need to have. We have an obesity epidemic. We have an opioid epidemic. We have a firearm violence epidemic. We've had a return of syphilis in babies because we have a rapidly growing STD epidemic. You know, we finally have the capability. I got into public health in 1990, and we finally have the capability to literally totally control HIV/AIDS. Think about that, you know? Mid-'80s to 2023, we now have medications that can dramatically diminish the amount of virus in a person's system and prevent transmission of a disease that has become a chronic disease in our lifetime, but of course is fundamentally life-threatening. We have hepatitis C, which is one of those mystery diseases that we used to have until we finally figured out we had a hepatitis C, but we now have medications that can totally cure it. They cost too much, but nonetheless, we are on the precipice of actually being able to control two amazing infectious diseases that are very, very costly to the system. And I think when we think about this, I like to look at what the Commonwealth Fund did. So the Commonwealth Fund periodically ranks the high-income nations, and on their ranking, we're 11th. But that's 11 of the nations that they have ranked. You know, Japan's on that list, Norway's on that list, Sweden's on that list, Britain, of course, and Canada are on that list. But the point is, they look at about 5 metrics, and those 5 metrics include access to care, the process in which care is delivered, administrative efficiency, equity, and healthcare outcomes. And when they do that, and then they look at what the top performers are on their rankings, they came up with 4 things that actually make their rankings make sense. Number 1, universality. We are the only industrialized nation that has not gotten to universal access to care. Now, I didn't say single payer. I said universality. No matter how you do it, getting a system with everyone in and nobody out. And I see Vinnie DeMarco there, and I know he's working on this. But getting that system in place is absolutely essential. Second thing, you know, many of you may know I trained in internal medicine, but really self-identify as an emergency physician. So that means I'm an adrenaline jockey. I love EMS. I love jumping on ambulances. I love bells and whistles and monitors and putting in central lines and all that kind of stuff. The tragedy is we do too much of that and not enough primary care. And one of the top performers, all these top performers, focus a lot on delivering primary care and care coordination and engaging people in ways that prevent bad things from happening, which is absolutely essential. I used to tell, I used to go up the Hill and they would talk about the fact that we have universal health care because we have emergency departments. And I would always tell them, stop. There are many things that I can do in an emergency department. You crash your Porsche, I guess I'm in the United States, right? You crash your Chevy. We can put you back together. The old bionic man and bionic woman stories. We're really good at that stuff. But I can't take care of a little high blood sugar or a little high blood pressure and, all those things that result in amputations and, diabetic retinal eye disease and a little bit of lung scarring here. And that does not happen in the emergency department. I don't care how many times you bring them to the emergency department, continuity of care does not happen. Quality primary care does not happen in the emergency department. It happens in a primary care setting, usually with a good care team. And so those high performers do that very well. The second thing they do is they figured out how to reduce administrative burden and the fractionalization of their systems. We have, I'm a good capitalist, but we have way too many systems and way too many things. And I remember being in the health department and having a major meeting because we were reconciling the money on the left side in Medicare with the money on the right side in Medicaid. And, we had to report to the feds about which money we had to have in our left pocket or our right pocket, and we were spending hours and hours and hours trying to make sure those systems talked to one another and they worked. Now, I believe in accountability. That's not about accountability. It's about the fact that, the number of people who call, so having hip surgery, I can tell you the number of people that called to want to make sure that I didn't have the hip surgery because I had an automobile crash, right? To make sure that the right person paid the bill. It's enormous. The administrative burden is in our system, it's estimated at least 20% of administrative costs for the overall system. And then not just the fact that we do that with our money, but we do that with our systems as well. The fact that you go into the hospital and then you get discharged, and the pharmacy on the first floor, they can't give you your medications when you're discharged from the hospital, so you can take them home with you. So what do? You gotta get in your car, not feeling well, go to the pharmacy of your choice, and get your medications filled. When I was the health secretary, I used to have a policy which basically said, if it's stupid, it's not our policy. We do things like that in the attempt to try to avoid fraud, et cetera, in an environment in which we have enormous data systems and the ability to collect fraud and abuse. We have these archaic systems which really don't serve patients very well. And so we have a lot of work to do. And finally, the fourth thing is this issue around the social determinants of health. Now, I think I'll come back and talk more in detail about that, but they spent a lot of time on social systems in their nations. And when we talk about the lack of universality, we have about, 27 million people without access to care in our nation. That number is a moving target, so whatever I said right now is probably different than 4 o'clock this afternoon because all the redeterminations that are going on in the country. We lost over 1 million people from the Medicaid program because there are some states, not Maryland, but there are some states that are eager to get people off the Medicaid rolls. In those states, they have a fundamental belief that healthcare is not a fundamental human right. They don't believe that people deserve to have coverage. And so anything they can do to get them off the rolls, they work to do that. Maryland, for good news, is that we have an opposite philosophy. We do everything we can to keep people on the rolls. And we should do more. There are many, many more things we need to do. The other problem we have, because we have a number of people who are underinsured. The number of people who have an insurance policy that they're struggling to pay, the number of people who, whatever the policy is they have, doesn't really cover what they need. Their co-payments and deductibles, we've done a good job of shifting costs off the premium onto co-payments and deductibles. So the out-of-pocket costs are soaring for many, many people. And it's resulting in uninsured, and functionally they're uninsured. Because we know that the minute you don't get first dollar coverage for these kinds of things, it's a barrier to receiving care. For lower income individuals, it can be as much as $5 or less that is an inhibitor for them to get care, because it may be the difference between money to go to work or money for your medications or money to see the doctor. So we have some work to do there. And we, of course, have those 10 states in our nation that have not yet expanded Medicaid. It is growing, 3 cheers in North Carolina for recently expanding Medicaid. But it continues to be an issue. The whole issue around costs continue to be the issue. And, it was interesting. I want you to think back. We just spent 2 years in this terrible, terrible COVID pandemic with a single payer, government-sponsored response to COVID. We paid for the medications, we paid for the vaccines, we paid for the testing, we enhanced the coverage, removed a whole range of barriers to try to improve access to care. And just want to make sure that everyone realizes that we did that. We did not destroy the private insurance market, nor did the world come to an end, unless this meeting's a fantasy, which could be. And I just think we need to think, before we start running out and looking at innovation, in systems that get everybody in, where there's a strong partnership between the private sector and government, which we did that as a strong partnership between the private sector and government. We kind of struggled our way into it, but we did it. And of course, now we've taken away, under the public health emergency, all that stuff goes away. And so now we're going back to the system. I would love to see people doing studies about healthcare coverage and outcomes during COVID and healthcare coverage and outcomes after COVID. If there's some way to do those kinds of studies, it'll be interesting to do. I mentioned that our system obviously loves specialized care. Not much more to say that, except that it's, every system is designed to get you the outcomes that you want. So, when I was the secretary, one of the last things we did was we were having trouble keeping primary care folks in the system. We began to pay primary care folks more. We're going to continue to have problems with over-specialization until we pay pediatricians and internists and folks practicing primary care to actually practice primary care. Take away those 15-minute visits because there's not a lot you can get in that 15-minute visit. And re-engineer the system in a way that it really, really, really focuses on primary care as a fundamental way of doing things. And this patchwork of things that we have, which is really stimulates overuse, underuse, medical errors, and does not do much for resolving our health inequity issue, is a big issue. I mean, obviously, depending on where you are, you can have disparities in inequity from in between African Americans and whites, white men, black men, Latin men. They're just enormous differences. I live in Gaithersburg, and the life expectancy in Gaithersburg is around 78. The last time I looked, and DC is around 71, 7-8 year life expectancy within, 15, 20 mile difference. That makes no sense. We have enormous differences in our systems that we need to do something about right now. One of the other revelations that I had when I went from, being a real doc, practicing in the emergency department, saving lives, being a hero, was that 80% of what makes you healthy occurs outside the doctor's office. That is a very, very painful revelation for someone who's an adrenaline jockey like I am. But it's true. Access to education, access to housing, those things are very important. Look, the solution to housing and homelessness is a house. There's no question about it. But it has to be affordable. It has to be of high quality. And we know that if you get a person into a home, you can stabilize their healthcare outcomes. You can link them to a primary care provider. That does not occur very effectively in the shelter. With thoughts to our colleagues here at Healthcare for the Homeless, who do an amazing job providing care for the homeless. But the solution is a house. We know that education, every society has looked at it. The outcome for that first year of life for a baby born to a woman who is better educated is important. The more education that a woman has, the better and more likely their child is going to survive their first year of life. It's probably a surrogate for other stuff, class, income, educational level. But it's been studied in many, many societies, and that correlation is still true. Education matters. And it matters in terms of survival, even for high school graduation. People who graduate from high school do extraordinarily better than people who don't graduate from high school. Transportation matters, where you live matters. From the ability to get around and get to work and get to school, We have far too many kids who live in communities that aren't walkable, bikeable, and green where they can see the school, but they've got to be bused to the school. Because we built our communities in ways that just aren't healthy, and which doesn't make a lot of sense. You know, where we dump our trash. I remember when I was a city health commissioner in DC, the 14th Street Bridge, wonderful bridge, brings people in from Virginia into the city. As you cross that bridge, you see the Washington Monument, the Jefferson Memorial, the White House is in the foreground. It's a beautiful view. But at night, these illegal trash haulers come across the bridge, and then they go right into wards 7 and 8 in DC, find vacant lots, and they were dumping their trash. And one of the public health interventions we did was putting people on that bridge to arrest, turn around, or find those people that were doing illegal hauling. But where we dump our trash is the big issue. It has all kinds of implications for groundwater safety and things like that. And yet, you know, we've got a recycling trash problem still that we're trying to deal with in our country. The point is that during COVID, those nations that had really, really, really strong social support systems did much better than we did. You know, they were able to send kids home because they didn't have to worry about, you know, access to IT, to internet. Those kids many of them had computers. They didn't have to worry about people being able to be covered for social supports when they're at home. We got there through a variety of jerry-rigged processes to provide social supports for people, but it was still a patchwork and it still was uneven. So we just simply don't spend enough on social supports. And by the way, that's not a trade-off between social supports and the military. It is really a trade-off between spending for health care and spending monies for social supports when you actually look at where the money comes from. So I personally believe that we ought to be amongst the healthiest nations. There's no question about that. And so as a nation, we need to do a bunch of things. We've got to get to universality anywhere we can. And by the way, we're close. The Affordable Care Act got us a long way, even though there's been enormous pushback. We need to make sure we get that universality. Major investments in primary care and care management is important. System simplification. Look, the fact that we don't have our health information highway, you know, President Eisenhower, when they decided they wanted to build a national highway system, the rationale was we needed to have a system that could carry tanks and move people quickly if we had to evacuate cities because of concerns about nuclear war and things like that. And so they built these systems and they basically connected all the roads, et cetera, in the country. They incentivized local communities with dollars to link things together. They had a master plan which created the national highway system. They've improved it over time. We got to do the same thing with our healthcare system. We really need to, at the national level, I know the Office of National Coordinator is working on this, but it's too slow. It's too slow. You know, I'm sitting at home the other night, you know, it's about 8:30, and I remember what I'm watching on TV, but some talking head about something that I really wasn't listening to. But I got hungry. So I pulled out my accessory brain, my iPhone, and pulled up DoorDash was the app of the moment, and DoorDash, I ordered the food, it links to the restaurant, it brought it to my house, it did it in under 45 minutes, it was still hot by the way, and was able to be paid for. Can I do that with the healthcare system anywhere on the planet? No. We still can't move an EKG across the street. We're still faxing health data in public health, not just at the local level, but the federal level. When I was a deputy health officer here, Marty Wasserman, some of you may remember Dr. Wasserman, made each health department, all 24 of them, buy a computer. And you would have thought that, you know, we were going to arrest them and throw them in jail. They were all upset. Finally, they bought a computer and they began using those computers, and they discovered suddenly they didn't have to run from Charles County for 2.5 hours during rush hour to bring data up so our state epidemiologists could work with them on a disease outbreak, because they had something called email that they could send information around. And they could all share the information on a telephone and talk to one another, which accelerated the use of computers. But we're still doing fax machines, and that's a challenge that we still have. So we've got things to do. By the way, we don't even still have a single patient identifier. We don't know if George Benjamin in Health System A is the same George Benjamin in Health System B. We've still got too many regulations in place that cause problems, and we haven't done anything about the social systems. And we're still thinking addressing the social determinants of health is getting someone to a social worker. It really isn't. Okay, that is important. We need to do individualized care, there's no question about that. But just know that what we really need to do is we need the health systems to spend their lobby dollars to help us with zoning reform. Liquor store density has a strong correlation between mental health in a community. Wouldn't it be neat if they showed up for those issues? I remember when I was the deputy health officer running 80% of the department and had most of the hearings on budgets. It would be me, the chair of the committee, their aide, my budget person, and the room would pretty much be empty. When I became secretary and I was running the Medicaid program, the room was packed full of people because of the amount of money on the table. I would like to see the room packed for the public health hearings to support those kinds of issues as well, because I think if we do that, we'll get a whole lot of other things. And then finally, as we're starting to think about where we need to go with our public health system, which has been decimated. We only spend about 3% of our healthcare dollars on public health. It is underinvested in. It continues to be underinvested in. The pattern is something really bad happens. The federal government, often a little too late and not quite enough money, but a major investment nonetheless, throws money at it. And then when they think they got the problem, their hand around the problem, not when you really got it all gone, they pull the money back. So that's exactly what they're doing. They've already started doing that. We put out $3.2 billion for public health, and then as part of the debt ceiling deal, we clawed back $1.7 billion. Different fund. That was specifically called back from CDC. By the way, those dollars ultimately would have gone for disease prevention, health promotion, things like that. And then they also took some money out of the emergency fund. They're going to redistribute some of those dollars, but there'll be a fight as to whether or not who gets them, and they won't all go to traditional public health services. So we've got this challenge that we have in terms of rebuilding the system, and it's not like we just had a pandemic which crashed the economy and killed 1.1 million people. We still have about 200 people a day still dying nationally from. It's not like that has gone away. It didn't, and yet the people want to move on, and that's really the problem. If we did that with our military, we wouldn't be able to defend our nation at all. And so I would argue that public health security and health security are very important, and we need to continue to invest with that. Maryland, we've done well. Depends on where you live, right? Obviously, you can imagine Howard County, Montgomery County, life expectancy is better than some of our more rural counties. That continues to be an issue. We have still got lots of work to do on the national level. Despite our amazing progressive history in the state of being very forward-leaning, that's very important. But we have more work to do. And then in closing, I always like to say that I believe that the goal in life is to live as long as you can, as well as you can, and have a short but glorious ending. And the only way to do that is to have a system that can achieve that is designed to get you that goal. And we can see it right over the hill, but we've still got a lot of work to achieve it. Let me thank you, and I'm happy to take any questions.
Thank you, Dr. Benjamin. So we have Patrick and April with mics coming up around the room. Let me start by asking you this. So, Dr. Benjamin, a lot of these challenges that you described nationally, public health infrastructure investment, primary care investment, care coordination, care management. From Maryland's perspective, what are our underutilized assets, strengths that we really need to get more effectively mobilized against those problems?
Yeah, I think one of the challenges we have for the next several years, of course, is to get everybody covered in Maryland. I think that's an issue. Second thing, of course, is getting our hands around costs. I know you have a prescription drug board that is working on the costs, and right now, prescription drug costs is the issue that we're all really, really, really worried about. But I think the missed opportunity is the waiver. The last iteration of the waiver was to begin to put our foot in the water to get kind of everybody else under that waiver at some level, and to begin to integrate that with some of the social needs that people need, as well as begin to address the social determinants. As you go through the next iteration of that, I think there's an enormous opportunity to make a very dramatic step forward, getting really everybody under that waiver in a meaningful way. Because I think that's the national model. I think universal coverage under an all-payer system is the national model to get us where we need to go as a nation. And I think Maryland can provide the leadership to get us there. The challenge everybody who's tried to do quote-unquote single payer is trying to figure out how to pay for it and how to control costs, and then how to make the transition. But it's sitting right here in front of us, right? The ability to get to universality. First of all, you have to say everybody needs to be covered. And then you have mechanisms that make sure everybody gets covered, just like we have mechanisms to make sure everybody gets auto insurance, right? The redetermination process that we have is burdensome, costly, and if we actually did the economics of it, probably regressive from an economic perspective as well. Just because once somebody loses that coverage, then there's a whole lot of other costs that we don't capture that actually make it more costly to go through that process. So we need to figure out how to get people in the system, keep them in the system. Again, Maryland it's a small enough state. We're almost there, getting everybody covered, and we have all the tools, and more importantly, we have an extraordinarily effective data system, right? Which was used during COVID very effectively, has been used to look at hospital costs very effectively, and we could certainly use that same kind of system for outpatient costs.
That's great. Thank you. Questions from the crowd? Questions for Dr. Benjamin?
Yes. Good morning, Dr. Benjamin. Robin Elliott, first I want to thank you for bringing me back to the health department way back. I'm not going to date myself and say when. But I wondered about your thoughts or your advice when we see how politicized public health has become, whether it is threatening or even arresting people for coming across the borders to get care, to what's happening with the FDA lawsuits, to school boards overturning because of mask policies. We are so polarized around public health. How do we get past that?
Yeah, so first of all, stop doing stupid stuff and don't allow it to happen. It's a failure of leadership. Let me start with that. Yesterday, well, if you are a judge in a courtroom, that behavior is not allowed, right? Judges simply don't allow that to happen. The bailiff knows what their job is, and if you misbehave in the courtroom, you get thrown out. You might get thrown in jail. We should not, allow that to happen in town hall meetings, or school board meetings, et cetera. We need to, have a system, and we allow the pro folks to say what they got to say in some time period. Those are the rules. And then the con people get something, you alternate them. And if people get out of line, then they have to get out of line. And if they're inappropriate, then they need to be handled with some kind of, accountability mechanism for that. And we need to train our public hearing groups to do that. I never, ever felt threatened. I remember going to the Eastern Shore of Maryland. This is when we were going to close the psychiatric hospital on the Eastern Shore. And there was a big debate about whether we were going to build a new hospital. At a time when we were trying to close hospitals. You may remember those days. And that was a pretty hostile meeting. But I never felt threatened. People were respectful but angry. I've been in HIV/AIDS meetings during the early part of the AIDS epidemic where people were angry, they felt abandoned, but again, I never felt threatened. Many of our public health officials nowadays feel threatened. Tom Dobbs, Mississippi health officer, felt very much threatened. And as Tom would tell you, I'm a big boy, I can handle being threatened, but they were bullying his kids at school. That has to stop. So first thing is, we have to demand the decor. We have to demand the respect. Our elected leaders need to grow up and behave as well. And if they're not going to behave, then we as voters need to make sure that they get different jobs. And that's not a political statement based on any particular political ideology. But I'm not going to allow them to treat me that way. And if they do, then I'll get up and go home, and I can do a lot of other things. So I think that that's one of the things we have to do. Second thing is, on the political side, we just have to make sure that what we're doing is sound policy. And we actually are in charge, believe it or not. We don't have to allow these folks, and remember that it's really a loud minority of people that are causing these challenges. They just have a large bullhorn, and we need to either have a larger bullhorn, or we need to, again, I'm not into stifling people's First Amendment rights, but there are times when people just need to shut up, and we need to let them know that.
Great. Any other last questions before we? Yes, please.
Hi, Maria Cachetta. I was born in Philadelphia, so my voice should be loud enough to resonate.
I'll restate your question, yeah.
Okay. So we have, I think the main part of the healthcare dilemma in the country is the slowness of healthcare to change. The medical providers, the understanding of what affects disease in people.
Yeah.
There's still a mindset that things can be handled by drugs. Okay, there's the lack of holistic medicine, there's a lack of integrative medicine. So when we talk about primary care, we really should be talking about integrative medicine, because you shouldn't have to go to 5 doctors to figure out what's wrong with you, because an orthopedist only knows hands, and he doesn't look at the neck, and doesn't look at a leg. There needs to be a change, and we're seeing the change, but it's coming along very slowly. So you have practices in Crownsville, you have them around Georgetown, you have them in certain pockets, and they don't exist largely in Baltimore. They don't, looking at immune disorders that cause a whole host of problems that manifest themselves as behavioral health or mental health conditions people are being treated as schizophrenics when they're actually having responses to Hashimoto's or to other disorders. So I think that there's a bigger question about what does it mean to provide good quality health care for the total person and their family.
Yeah, the question is how do we get to integrative care from just primary care as a issue. And in our country, things are driven by money. There's no doubt about it. We've got to decide as a value that we want to value that, put more resources into it, and demand that our systems do it. But at the end of the day, we've got to decide that's what we want. And that changes the whole pipeline of who we train, what we train them to do, et cetera. You know, when I went to medical school, I spent a whole lot of time taking a medical history and a social history. And then promptly, when I began to practice, we never used it. And so we need to start using it. Now, part of that is, as we shrunk the amount of time that the clinician has with the patient in the room, I'm not sure, we certainly have not optimized that care. So yes, we need more team-based care. We need to figure out what the real periodicity is to see patients, and we need to see what the right time limit is to get all the things in that we need. We keep cramming more things in that need to get done in a shorter period of time, and then we're surprised when we're not getting the outcomes that we need. And I think we need to. There's clearly a need to relook at that. How do we speed up the utilization of more efficient or better health care, or even better health within our system? It's going to be forced on us. If anyone thinks that this fast science, fast technology, fast communication is not going to result in fast changes in health care, I think we're fooling ourselves, and we have two options. We either, as professionals who are trained to do this stuff, either change quickly, or someone else is going to come along and into our space and do it, and we'll find ourselves looking from the outside. So I think it's very important for the guilds to have a step back and, you know, stop making up excuses. There's always quality care is going to be an issue, and I'm always looking for the patient's best interest. No. Sometimes we are, but sometimes we're also protecting our turf, our pocketbooks, et cetera. And we need to do some introspection, I think, to figure that one out.
Great. Dr. Benjamin, thank you so much for kicking off our day. It's been wonderful. Thank you so much. And enjoy the day.